Right. Just share my slide. Right. Hello, guys. Hello, everyone, and welcome to episode 3 of our Hot Topics in Cardiology webinar series. So my name is Ezman. I'm one of the co-directors alongside Dr. Misato Chimura. She apologizes because I think her video is not working, but she is with us today. And episode 3, we'll be talking about cardio-kidney-metabolic syndrome. And we have a wonderful list of chairs, panels, and also speakers today. This particular episode is in collaboration with APCMC. And together with me, chairing is Dr. Misato Chimura, as I've mentioned, consultant cardiologist from Osaka University Graduate School of Medicine, Japan. We have two wonderful panelists who are from the APCMC group. First, Assistant Professor Chanchal Chandramoli, Senior Research Fellow and Assistant Professor from the National Heart Centre of Singapore and Duke NUS Medical School Singapore, as well as Assistant Professor David Liu Tak Wai, Clinical Assistant Professor and Consultant Endocrinologist from University of Hong Kong, Hong Kong. So we have two wonderful speakers, Dr. Natalie Koh, Senior Consultant Cardiologist from National Heart Centre of Singapore, who will be talking about GLP-1 receptor agonist in ABCD, or Adiposity-Based cardiovascular disease. Dr. Natalie Koh is not with us today. She sends her apologies, but we do have a pre-recording which she has kindly done for us, which we'll be playing, and hopefully we'll do justice to her talk through our panel discussion. And our second speaker is Dr. Leonardo Paskah Suciadi, consultant cardiologist from Siloam Heart Institute and Siloam Hospitals, Kebon, Jeruk, Indonesia, who will then be talking about a new era in DKD, or diabetic kidney disease, building a foundation with the 4 pillars. Some disclaimer and housekeeping rules. The content of this webinar is copyrighted by the APSC. The views and opinions expressed are those of the faculty members and do not necessarily represent those of the APSC. This webinar is live streamed via APSC Facebook and YouTube pages, and you will receive your certificate of attendance upon completing a survey sent via email post the webinar. Now, please feel free to enter your questions into the Q&A chat box and interact with us throughout the session, and hopefully we can get through all the Q&A questions that you post. Just a reminder that in May next year, we'll be having our APSC 2026 Congress, and which is run in conjunction with the Taiwanese Society of Cardiology Congress, which is again in Taipei International Convention Center and Taipei World Trade Center, Taiwan. So without further ado, let's get started. And now we'll be playing Dr. Natalie Koh's pre-recorded talk on GLP-1 receptor agonist in ABCD.
Hi, good evening, and welcome to APSC Hot Topics Episode 3, GLP-1 receptor agonists in adiposity-based cardiovascular disease. Hi, I am Natalie Koh from the National Heart Centre of Singapore. Very delighted to be invited to present this topic today. So first, I'd like to bring us through what would be a typical presentation and management of a patient with cardiometabolic disease in my clinic. So this is a 54-year-old man, Mr. M, who was referred to my clinic with the following. He has paroxysmal atrial fibrillation, he has OSA and declined CPAP, and he had obesity. His BMI was 33. A baseline echo showed a normal ejection fraction of 60%, mild LA dilatation, and mildly elevated E over E prime, although he had a normal NT-proBNP on a normal EGFR. So after discussion with the patient, I started him on off-label Ozempic. In Singapore at that time, we did not have Wegovy nor tirzepatide. We started him on off-label Ozempic, titrated to 2 milligrams per week, initiated lifestyle management. He declined referrals to physiotherapy, occupational therapy, or dietitian. So he did this without supervision. And we had a target weight upfront set for 85 kilograms for 17% weight loss to target a BMI of 27 from 33. And his weight trend was pretty good. He managed to achieve, at the end of 24 weeks, a weight loss from 102 kg to 87 kg, at which point he decided that he would like to down titrate Ozempic to 1 milligram per week at week 24 due to cost concerns. So, what could the future of obesity management look like? How would we improve with the tools that we have at hand and the latest evidence on the present management? I think it's incumbent upon us to talk about the relationship between obesity and cardiac arrhythmia. Obesity is a powerful independent risk factor for both atrial and ventricular arrhythmias. Epidemiologically, each 5-unit rise in BMI confers a 16% higher risk of sudden cardiac death and a 29% greater risk of new onset atrial fibrillation. It also increases the likelihood of post-operative atrial fibrillation by 10% and post-ablation recurrence by 13%. Altogether, obesity may account for 20% of all atrial fibrillation cases and up to 60% of the recent rise in AF prevalence. And beyond incidence, obesity drives the progression from paroxysmal to permanent atrial fibrillation, largely through left atrial remodeling, volume overload, and inflammation. Mechanistically, it promotes left ventricular hypertrophy, QT prolongation, ectopy, and autonomic imbalance, forming the substrate for both atrial and ventricular arrhythmias. Even mild to moderate obesity is associated with greater risk of VTVF and late potentials, underscoring a continuum of arrhythmic vulnerability. Clinically, obesity is now recognized as the most common non-ischemic cause of sudden cardiac death. Given that sudden cardiac death accounts for roughly half of all cardiovascular deaths, obesity now emerges as a key modifiable public health target. We also look at adiposity and heart failure, and there is a clear relation between body mass index and the risk of HFrEF and HFpEF, with the various mechanisms seen on screen as to the pathophysiology of heart failure in obesity. So when we talk about the pillars supporting obesity management, we have the medical nutrition therapy, physical therapy, and various different interventions beyond lifestyle modification. Psychological and behavioral interventions encourage up to 5% weight loss, and pharmacological therapy encourage 5 to 15% weight loss. And currently we have this in our armamentarium, although in cardiometabolic disease, it's difficult to ignore the cardiovascular imperative and the cardiovascular benefits from GLP-1 receptor agonists, as well as the dual GLP-1 and GIP receptor agonists, tirzepatide. And bariatric surgery, 12 to 15% weight loss. So we see that with pharmacotherapy, the modern pharmacotherapy with cardiovascular benefit, we can achieve up to bariatric level amounts of weight loss. So current weight loss medications have limitations, but the future does look very promising. Bariatric surgery used to achieve greater weight loss than medications, but is not widely accessible and is also morbid. Current medications such as the GLP-1 receptor agonists do have their limitations. Less weight loss compared to surgery, yes. That was in the past before the dual incretin agonist came on board. Varying effectiveness depending on factors like diabetes. We know that patients with diabetes do respond less well to these medications in terms of the amount of weight that they can lose. And for many, an injectable medication could prove a barrier to entry. There are now further advancements in Singapore. We now have dual incretin agonists like tirzepatide for obesity management that is approved. Oral GLP-1 receptor agonists are being developed for easier use and potentially better adherence. And a new generation of medication targeting enteropancreatic hormones is under development with the aim to enhance and or complement the efficacy and mechanisms of action of GLP-1 receptor agonists. So for the evidence of obesity treatment in atrial fibrillation, this is our current landscape, and these are the key evidence and trials that show outcomes. And I think if we go down the table of the summary in the atrial fibrillation context, we see that lifestyle and weight loss programs in the atrial fibrillation context, trials like BE Well in CRAF, and prior observational and cohort data do suggest that we need at least a 10% weight loss to improve atrial fibrillation burden, reduce recurrence post-ablation, and for symptomatic improvement. These trials were mostly non-randomized or small, and there were many confounders as well as adherence challenges. And when it comes to bariatric interventions, we have some observational and ablation adjunct trials which show that weight loss before ablation is associated with better outcomes, such as lower recurrence and fewer complications. In SORT AF, obese patients had similar safety but benefit from adjunct therapy. Again, not many RCTs. There's a selection bias, procedural risk, and also it showed, and there was also weight regain over time that confounded the findings. When it comes to GLP receptor agonists and anti-obesity medications, we have recent pharmacoepidemiologic observational studies like the Transform AF study, which found that in 2,510 atrial fibrillation patients with obesity, that the GLP-1 receptor agonist use was actually associated with 13% lower rate of atrial fibrillation related events over 3 years, despite maybe only a modest weight loss. The problem with the trial was that it was not randomized. There were also some confounders. So overall, when it comes to studies of obesity treatment in atrial fibrillation, there are promising observational data that has been published to date, but I think the evidence is still emerging from RCTs. So this was the Transform AF trial that was presented at Heart Rhythm in 2025, April this year in San Diego, which showed that at the median follow-up of 3 years, GLP-1 receptor agonist use was associated with an approximately 13% lower risk for major secondary AF-related events versus the use of DPP-4 inhibitors or sulfonylurea used among patients with diabetes, atrial fibrillation, and obesity. And the greatest benefit was actually seen in the patients with the greatest BMI category, a BMI greater of 40 kg per meter squared. So when we look at, aside from atrial fibrillation, when it comes to obesity and cardiovascular disease, what are some of the other relevant clinical trials? To organize the discussion going ahead, we'll talk about obesity and MACE reduction in the SELECT trial, obesity and HFpEF. We have the STEP-HFpEF, STEP-HFpEF, DM, and SUMMIT trials. And then we will focus on the dual incretin agonist tirzepatide, specifically tirzepatide's benefit in obesity, as proven in the SURMOUNT-1 trial, and the tirzepatide in type 2 diabetes and cardiovascular disease, the SURPASS CVOT trial. So let's look at some of the obesity and HFpEF trials. These are the 3 trials that I have highlighted: the STEP-HFpEF trial, STEP-HFpEF DM trial, and the SUMMIT trial. So the heart failure symptoms and signs that were studied across the 3 trials, the recruitment was for NYHA 2 to 4. The LVEF cutoff was slightly higher in the SUMMIT trial, greater than 50%, versus 45% in the STEP-HFpEF cohorts. The NT-proBNP in the STEP-HFpEF cohorts was the criteria is as seen on screen, and they had differential criteria based on BMI less than 35 or greater than 35. At the structural echo criteria, left atrial enlargement or LVH was required for the STEP-HFpEF cohorts. Likewise in SUMMIT, and SUMMIT also had additional criteria for elevated LV filling. The NT-proBNP thresholds were as such for the AF cohorts across all 3 studies. BMI requirement was greater than 30 kg per meter squared. STEP-HFpEF actually studied functional assessment, the 6-minute walk test, walking distance, In the summit study, it was important to note that there was a very interesting imaging sub-study for cardiac MRI in about 106 patients, which actually studied the LV mass hypothesis in weight loss. Yeah, we will discuss that later. So the semaglutide 2.4 milligram was studied in an extensive clinical trial program known as the STEP program across multiple patient populations. And the STEP HFpEF program studied once weekly semaglutide 2.4 milligrams in patients with the obesity phenotype of HFpEF, both with and without diabetes. So why is SELECT so exciting for us in the cardiometabolic field? That's because it is the first cardiovascular outcome trial of GLP-1 receptor agonist in persons with obesity and established CVD without diabetes. So it was to demonstrate the superiority of semaglutide 2.4 milligrams weekly versus placebo on 3-point MACE. And it was a very large study of 17,605 participants with key inclusion criteria of age greater than 45, BMI greater than 27, established CVD as evidenced by one or more of the following: prior myocardial infarction, prior stroke, or symptomatic peripheral arterial disease, and specifically patients with type 2 diabetes were excluded. The primary endpoint was from time of randomization to first occurrence of a composite 3-point MACE endpoint of CV death, non-fatal MI, and non-fatal stroke. And the secondary endpoints were time from randomization to occurrence of CV death, composite heart failure endpoint, consisting of heart failure hospitalization, urgent heart failure visit or CV death, and all-cause death. And we see a very wonderful separation of the curves for the primary composite endpoint, hazard ratio of 0.8 with a p-value of less than 0.001 for superiority, and showed that semaglutide 2.4 milligrams weekly significantly reduced the risk of MACE by 20% compared to placebo in patients with obesity and established CVD without type 2 diabetes. And this was the first trial that showed this in a non-diabetes cohort, the benefit of this drug in patients with obesity for MACE reduction. All three components, death from CV cause, non-fatal MI, and non-fatal stroke, contributed to this MACE reduction. And the mean follow-up time was about 40 months. And we see that the semaglutide 2.4 reduced the risk of death from CV causes by 15% compared to placebo in this secondary endpoint analysis. The result was not statistically significant, crossing the confidence interval of 1, but suggested a benefit of semaglutide 2.4 milligrams weekly. And it reduced the risk of composite heart failure events by 18% compared with placebo. Superiority testing was not performed per the hierarchical testing procedure, even though the 90% confidence interval was less than 1. Again, a nice separation of the curves for the third confirmatory secondary endpoint of cumulative incidence of death from any cause, showing that this was reduced by 19% compared with placebo. Significant changes to body weight were seen in the semaglutide arm, and we can see that there was a 9.4% mean change in body weight compared to 0.9% for the placebo arm. And the conclusions from this landmark study in the patients with obesity and cardiovascular disease showed that semaglutide 2.4 milligrams significantly reduced major adverse cardiovascular events by 20% compared to placebo in patients with established CVD and who were overweight or obese without type 2 diabetes. And it had consistent beneficial effects across measured cardiovascular endpoints, with results suggesting a benefit of semaglutide on the risk of CV death, HF composite endpoints, and all-cause death. And the select safety findings were consistent with previous trials with semaglutide, confirming the well-established safety and tolerability of this medication. And it was the first time a weight medication had shown reduction in CV events in patients with established CVD and overweight or obesity without type 2 diabetes. So these are some of the postulated mechanisms as to why the GLP-1 receptor agonist class is so effective. And I think it goes down to the anti-atherosclerotic effects that are proposed, both the direct effects on improved endothelial function, reduce smooth muscle activation, reduce vascular inflammation, and reduce lipid accumulation, as well as the indirect effects on other cardiometabolic risk factors such as blood pressure, weight, and HbA1c, all being reduced. So the STEP-HFpEF trials goal was to evaluate the effect of semaglutide versus placebo in patients with obesity phenotype of HFpEF with and without type 2 diabetes. Okay. So these were the key inclusion and exclusion criteria from STEP-HFpEF and STEP-HFpEF diabetes. And it was a randomized, double-blind, placebo-controlled trial across multiple sites. And we noticed that there was also Asian representation in these cohorts. And they were randomized to receiving semaglutide 2.4 once weekly versus placebo. And as discussed, these patients had NYHA 2 to 4, heart failure, EF greater than 45%, BMI greater than 30, and had no type 2 diabetes. Primary objective was to study whether or not study semaglutide once weekly's effect on physical function, symptoms, and body weight compared with placebo. Both added to standard of care in patients with obesity phenotype of HFpEF and no type 2 diabetes. And the key endpoints were a dual primary endpoint of change in KCC, QCSS, and body weight from baseline. And there was a significant improvement in the dual primary endpoint of KCC, QCSS compared to placebo at week 52. And also a decrease in the mean body weight. I think the mean change in the body weight in this cohort was a reduction of 13.3% from baseline, with 2.6% compared to the 2.6% of placebo. And there was also a significant increase in the mean 6-minute walking distance with semaglutide 2.4 versus placebo. And it did show a lower rate of SAEs, but a higher rate of adverse event-related discontinuations compared with placebo. And the overall conclusion for the STEP-HFpEF results support a favorable benefit-risk profile of semaglutide 2.4 milligrams for the treatment of patients with the obesity phenotype and heart failure with preserved ejection fraction. It was superior to the placebo with respect to the change in baseline at 1 year for KCC QCSS, body weight, 6-minute walking distance, as well as CRP, and the hierarchical composite endpoint of mortality, heart failure events, KCC QCSS, and 6-minute walking distance. It was generally well tolerated and is consistent with the previous experiences for semaglutide. Now, we're going to talk about the dual incretin agonist, tirzepatide. What is tirzepatide? It is a dual incretin receptor agonist acting on both the glucose-dependent insulinotropic polypeptide receptor as well as the GLP-1, the glucagon-like peptide 1 receptor. And I think it's marketed as Mounjaro for type 2 diabetes and Zepbound for obesity. The dual incretin receptor activation enhances glucose dependent insulin secretion. It suppresses glucagon, slows gastric emptying, reduces appetite, and increases glycemic control and promotes weight loss. The GIP receptor agonist stimulates insulin secretion, modulates adipose tissue metabolism, and enhances insulin sensitivity, and further amplifies GLP-1 receptor-mediated effects. There is overall synergistic incretin signaling with greater glucose lowering and weight reduction than selective GLP-1 receptor agonists. And this is the clinical trial evidence for tirzepatide. The clinical trials for SURPASS 1 to 5 in type 2 diabetes cohorts showed significant reductions in A1C of up to 2%, weight loss of absolute weight loss of between 5 to 12 kg, and it was superior to insulin as well as semaglutide 1 milligram weekly. Surmount trial studied in the obesity cohort without diabetes showed a median weight loss of 22%, 24 kg in the study. Has received labeled indications for diabetes as well as weight loss. Summit, which was published in NEJM in 2024, in the obesity and HFpEF cohorts, showed a reduction in cardiovascular death and heart failure hospitalization. A 38% reduction, hazard ratio of 0.62. And this was a co-primary endpoint, largely driven by a reduction in the hospitalization for heart failure. And then Surpass CVOT, that is still pending publication in a peer-reviewed journal, studied the tirzepatide in the type 2 diabetes and established ASCVD cohort. And it showed that the tirzepatide arm was non-inferior to dulaglutide for 3-point MACE with a reduction in all-cause mortality of 16%. And we will dive deeper into Summit and Surpass CVOT trials. Okay, so this is the Surmount data showing that subcutaneous tirzepatide led to clinically meaningful and sustained weight reduction in obese adults without diabetes. And this is a Summit trial that studied the long-term effects of tirzepatide on major adverse heart failure outcomes in a cohort of 731 patients with a mean BMI of 38 kg per meter squared, a mean probability of HFpEF of greater than 80%, and substantial limitations on health and exercise capacity. And patients were randomized 1:1 to receive tirzepatide up to 15 milligrams subcutaneously weekly or placebo for up to a median of 104 weeks. And the primary endpoint was a worsening of heart failure events in the tirzepatide group versus the placebo group. And it found a hazard ratio of 0.54, a 46% reduction with no difference in cardiovascular death. The conclusion from this study actually showed that tirzepatide reduced the risk of CV death or worsening heart failure and improved health status in patients with heart failure with preserved ejection and obesity. And you can see the separation of the curves to the right of the screen for the tirzepatide arm, and a significant, very nice hazard ratio of 0.62 and a significant p-value of 0.026. But what is also very interesting that I wanted to highlight from the Summit trial is the secondary analysis that you see to the bottom right of the screen. This secondary analysis presented at the AHA in 2024 and published in JACC looked at the effect of tirzepatide on cardiac structure and function in 106 patients from the main Summit study. And this cohort actually underwent imaging to analyze LV mass and epicardial adipose tissue at baseline and at 52 weeks. And the results actually showed that tirzepatide decreased LV mass by 11 grams and decreased pericardial adipose tissue by 45 mils in the treated group compared to the placebo group. And epicardial adipose tissue did decrease in both groups. And, the researchers do propose that perhaps the decrease in heart size may be a contributing factor in the reduction of heart failure events seen in the main Summit trial. They do propose that I think this is a nice imaging study for the proposed mechanistic reasons behind the results we are seeing in these obesity HFpEF studies. So now this brings me to the Surpass CVOT trial, a very exciting study and the first of its kind to study dual incretin agonist with a GLP-1 receptor agonist. So this studied tirzepatide versus dulaglutide in patients with type 2 diabetes and ASCVD. They were random. These patients with type 2 diabetes and ASCVD above the age of 40 and a BMI of greater than 25 and an A1C of between 7 to 10.5%. Of 13,299 patients were randomized into receiving tirzepatide or dulaglutide with a primary endpoint of time to first occurrence of 3-point MACE studied and select secondary outcomes, which I will soon present. The very exciting study was the first ever head-to-head CVOT phase 3 trial of two incretin-based therapies in adults with type 2 diabetes and established ASCVD. The primary objective of this trial was to study the efficacy of tirzepatide compared with dulaglutide on the primary endpoint of time to first occurrence of composite endpoint of death from CV causes MI or stroke when added to standard of care in participation in patients with type 2 diabetes and established ASCVD. And it was initially to determine non-inferiority of tirzepatide compared with dulaglutide on the primary endpoint, and then to determine the potential superiority of tirzepatide compared with dulaglutide. The key secondary objectives were to study tirzepatide compared to dulaglutide for time to first occurrence of the expanded composite outcome of CV death, MI, stroke, or coronary revascularization, time to first occurrence of CV death or heart failure requiring hospitalization or urgent heart failure visit, time to CV death, time to all-cause death, and a change from baseline to 36 months in eGFR in patients with high-risk chronic disease. And this was the study design, escalating of tirzepatide from time of randomization 2.5 all the way up to 15 milligrams. And these were the results for the primary endpoint, showing a hazard ratio of 0.92 and a significant p-value for non-inferiority, but not for superiority. And these were the key efficacy endpoints studied. And you will see that across the key endpoints studied, the significant differences were actually in the CV death and MI stroke coronary revascularization, showing a hazard ratio of 0.88 and a significant confidence interval of less than 1. And also in all-cause death, we see a hazard ratio of 0.84 with confidence interval not crossing 1. Drawing your attention to the composite of cardiovascular death, MI, stroke, or coronary revascularization, 12% relative risk reduction, significant confidence interval in the secondary endpoint analysis, as well as the all-cause mortality, 16% relative risk reduction, significant confidence interval less than 1 in the secondary analysis. Importantly, it showed a change in baseline significantly in favor of the tirzepatide arm for HbA1c as well as body weight reduction, 1.7% versus 0.9% for HbA1c reduction at 36 months, and 12.1% versus 5% change in baseline body weight to 36 months at the end of study. And this was the indirect estimate of the tirzepatide effect versus a putative placebo, which basically matched the population of Rewind. In summary, what this data tried to study was what it would look like if you were to have tirzepatide versus a placebo. And it was actually a statistical analysis of the data. And it actually did show that it would in an adjusted indirect estimate of tirzepatide versus the placebo. These are some of the very significant hazard ratios that we see on screen. Why this analysis matters is because Rewind used placebo as a comparator, but Surpass CVOT used dulaglutide which is a GLP-1 receptor agonist with proven CV benefit as a comparator. And this putative analysis indirectly estimates how tirzepatide would have performed versus placebo using the matched Rewind population. And it helps position tirzepatide in the same context as other GLP-1 cardiovascular outcome trials, such as Leader, Sustain 6, and Rewind. And I'd like to highlight some of the results on screen. And when we see the composite of cardiovascular death, MI, or stroke, the adjusted indirect hazard ratio versus placebo is 0.72. which was 28% relative risk reduction, composite of the CV death, MI, stroke, or revascularization. We see a 20% relative risk reduction. It's a consistent direction of benefit across expanded cardiovascular endpoints. And for all-cause death, it had the strongest signal of 0.61 hazard ratio, a 39% relative risk reduction in mortality versus placebo. And in cardiovascular death or heart failure events, a hazard ratio of 0.7, supporting the broad cardioprotective potential of this dual incretin agonist. And in summary, for the SURPASS-CVOT top-line results, it achieved non-inferiority to dulaglutide for 3-point MACE with a hazard ratio of 0.92, meeting the pre-specified non-inferiority margin. All-cause mortality showed a 16% reduction, relative risk reduction. There were improvements in A1C, weight, renal function, and overall mortality. To highlight the kidney findings of an eGFR decline that slowed by 3.5 mils per minute per 1.73 meters squared at 36 months versus dulaglutide. And in the indirect comparison versus a putative placebo, a very significant relative risk reduction of 39% in all-cause mortality and then 28% in 3-point MACE. So the final results are yet to be published in a peer-reviewed journal, but indeed very exciting, showing an ever-increasing armamentarium that we have to treat ABCD. So now I think I will summarize the trials that we've gone through, and it has been a pretty intense session. Apologies. It has been a pretty intense session of multiple trials presented, but I hope to reiterate that in all these trials that have been published, that there are many advantages to be had in the pharmacotherapy for cardiovascular prevention and cardiovascular improvement in patients with obesity. Yeah, so select STEP-HFpEF and STEP-HFdM. I think this is the one slide we will want to screen grab. And then this is a summary for the trials that we discussed for tirzepatide, for SURMOUNT-1, for obesity and overweight patients without diabetes, what the benefits are, SUMMIT, and then also for SURPASS-CVOT. So there are some upcoming CVOT trials that I'm keeping my eye on. I think that are very exciting for the field. SURMOUNT-MMO will assess the impact of the dual GLP-1 receptor, dual GLP-1 GIP receptor agonist and cardiovascular outcomes and all-cause mortality for people with obesity without diabetes. This is the tirzepatide select equivalent study. And then we will have the REDEFINE 3 study to study the impact of cagrilintide in patients with obesity, and then the oral GLP-1 receptor agonist to demonstrate the cardiovascular safety in these cohorts. So for a summary of the insights that we have today, I think obesity is a therapeutic target based on the pathophysiology of obesity in various in cardiovascular outcomes as well as atrial fibrillation. Specifically, we see that in SELECT, treating obesity pharmacologically reduces major CV events even in patients without diabetes. There are HFpEF benefits from the multiple STEP-HFpEF trials as well as SUMMIT. We see the mechanistic insights in the studies ranging from weight loss, anti-inflammatory effects, improved filling pressures, reduced cardiac fat mass that likely drive benefit. And we're awaiting ongoing confirmation to clarify the MACE impact for dual incretin agonists and awaiting the publication of the SURPASS-CVOT trial in a peer-reviewed journal. And I think, we have moved from metabolic drugs to cardiometabolic therapies, spanning ASCVD, HFpEF, as well as obesity-related risks such as atrial fibrillation. This class of drugs, the GLP-1 as well as the dual GLP-1 receptor agonists have really are really shaping the future of practice in the cardiometabolic field. So back to discussing what could the future of obesity management look like. The potential implications and challenges with new pharmacotherapies. Aside you know, from their benefits, we need to understand that when we reach bariatric levels of weight loss of up to 20%, um, we do need to realize the potential implications of such a magnitude of weight loss. Um, we will need to actually have longer term follow up of these patients to ensure the adherence, the management of nutritional shifts as these magnitude of weight loss occurs, similar to what happens in bariatric surgery, and also the pace at which the weight is lost and maintained across a lifetime requires, longer term follow up, consistent adherence to these medications. Yeah. I think also it's important to note that there is a heterogeneity in response and tolerability to these injectables. Patients with type 2 diabetes do not achieve the same magnitude of weight loss as studied in clinical trials on these medications. Firstly. Second, there's also a discontinuation rate that cannot be ignored. 5 to 15% of patients actually did discontinue these drugs due to the adverse effects. And in some of the dual agonists, we do incretin agonists, we do see up to 20-30% of discontinuation in phase 2 trials. So this, we need to keep an eye on the tolerability of these drugs as well. And the third thing to be reminded of is that although these drugs are very exciting and a less morbid option for many patients, ultimately bariatric surgery remains a durable, safe one-time solution, or 1 or 2 time solution, depending on weight regain for patients, and is also something to be considered, especially in patients with morbid obesity. Yeah. Number one, and also patients with limited access to pharmacotherapy for various reasons. So I think as we mentioned earlier, the when it comes to rapid weight loss and electrolyte shifts, the multidisciplinary team focus should shift to nutritional support during the rapid weight loss phase, cognitive behavioral therapy to support long-term weight maintenance, and to highlight some of the risks of acute weight loss, such as cholelithiasis, micronutrient deficiencies, and lean muscle mass loss, to avoid obesity-related sarcopenia. So it's actually an all of team effort, and prescribing physicians need to be aware of this in order to mitigate some of the effects, even absent a multidisciplinary team management, which many of us don't have access to. As prescribing physicians, we should be aware and have resources at hand to refer patients to, such as physical therapy, nutrition support, and psychotherapy support as needed. So when it comes to Mr. M, the patient that I had brought up earlier, and who we discussed the management for, I think in the future, in light of new developments in the field and ever increasing ability for medication to keep weight off, and ever emerging evidence for obesity related comorbidities beyond the cardiovascular health, we would want further evaluation of obesity related complications such as MESL D, a more in-depth review, perhaps additional imaging to confirm HFpEF, or the presence or absence of HFpEF. For the management, when we look at therapy, we choose therapy based on patient profile, their preferences, and also their associated obesity-related outcomes. There would be targeted weight and the rate of weight loss planned with patients, and hopefully multidisciplinary management for CBT, nutrition, and lean mass preservation. I think we would hope for surveillance, increased surveillance, the rate of weight loss plotted with the medication to allow for individualized adjustments across the timelines when it comes to titrating the medicines, especially in the context of dual incretin agonists, to be ready with alternatives in the event of adverse events, surveying of weight loss complications, as mentioned, the micronutrients, obesity-induced sarcopenia, and cholelithiasis among some of them. And you know, I think when it comes to the access and equitability, it's beyond the scope of this talk, but would require policy discussions on national level, perhaps protocolized and decentralized care for a condition as ubiquitous as obesity could also reduce overall healthcare costs. And I thank you so much. And I'm afraid I was not able to be present today, but I hope this was useful for everyone. Thank you.
So thank you so much. So thank you for taking the time to give us such a wonderful lecture. So my video was not working, so I will have to proceed with audio only. My apologies. So she explained in detail the relationship between obesity, heart disease, and arrhythmia, as well as RCTs on GLP-1 receptor agonist related to CVDs and heart failure. So there are a lot of things we would like to discuss, but since the time is limited, so I will ask just one question. So we received the question from the audience, but we answered it late. It's fine, okay? So I would like to ask David. It's fine.
Yeah, sure.
So my question is, so this is about GLP-1 receptor agonist and their effect on sarcopenia and bone disease. So
Yeah.
in Asia, severe obesity is less common than in Western countries. So could weight loss lead to decrease in bone mass? So since you have done a lot of research on bone health, so please.
Yeah, so thank you for your question. I think the interesting thing is that there is a worry about the weight loss leading to bone and muscle loss. So apparently there are some observational data that recently supported, first of all, with the weight loss, there is really a loss in both the lean and fat mass. There are some suggestion that possibly the loss in fat is more than the lean mass. And there are also additional saying that the benefit in terms of the muscle function as well. So it's probably not just the loss in the lean mass, although of course with the loss in the body weight, there is loss of lean mass, but proportionately, there are actually more fat mass that is being lost. And that sort of loss in the lean mass, in that sense, does not lead to impairment in the muscle function. So there are some data that is from observational studies that should support this thing. Of course, ongoing studies would be beneficial to confirm this observation. As for the effect of GLP-1 on bone loss, there has been some study, not only an observational one, but also there is a randomized controlled trial that suggests there are one trial that suggests it's a semaglutide use because of the increase in the I mean, it's more potent in terms of weight loss among the GLP-1 receptor agonists. It might be associated with bone loss. So the issue is about how we actually advise the patient to maintain bone health while the patient is on GLP-1 receptor agonist. In particular, we're now talking about all these potent incretin-based therapy. So it's important to advise the patient maintain adequate nutrition, in particular with the bone health, attention to the calcium and vitamin D supplements. And also there are some suggestions maybe exercise. Maintaining an active lifestyle would also be helpful to preserve that sort of bone loss. But of course, I think the way onward is that with the more potent gut hormone-related therapy, in particular like tirzepatide, this issue of bone and muscle health would become more and more important, as there are also studies underway that with addition of some targeted therapy, which might help to preserve muscle loss while on weight loss therapy. So I think it's an exciting field. People who are involved in weight management should be bearing in mind that the bone health issue, while I think at the moment there are some data to suggest that with the weight loss therapy, the muscle quality might not be affected. But to be honest, for those with at a very high risk of sarcopenia, I think that warrants further studies in this particular at-risk group of patients with sarcopenia, whether these more potent weight loss therapy might affect these patients.
Well, thank you so much. Very great answer, and you give me a lot of advice to prevent bone loss. So thank you so much. So we have limited time. So shall we move to the next lecture? Is fine.
Yeah, I think we should move on to the next lecture. Yeah.
So next speaker is Dr. Leonardo. So please prepare your slide and can you share your slide?
Yeah.
Yes. So his title is A New Era is Diabetic Kidney Disease. So please start your presentation.
Thank you, Misato. Good evening, everyone. So I will continue the talk about the cardiometabolic field. Today, my task is to talk about diabetic kidney disease. I'm not a nephrologist, actually. I'm cardiologist, just like you all. So I will present this as the cardiology perspective in CKD in patients with diabetes. So bear with me. This comes not without any specific reason why we are cardiologists need to understand about this topic of cardiometabolic, particularly for the cardio, kidney, and metabolic factors. Because nowadays we are very common to see our patients getting bigger and bigger with multiple cardiovascular risk factors, including diabetes and CKD. So without knowing this all, strategy how to manage them is really impossible to treat the patients with cardiovascular disease, particularly in heart failure, effectively or comprehensively. So we need to understand this all. And heart failure, diabetes, and CKD are strongly connected among each other. We already know about the bidirectional relationship between cardiac and also renal, namely as cardiorenal syndrome since a long time ago. And nowadays, we need to reckon that diabetes status plays also an important role in these correlations and put it more risk to these situations. The similarities between these three chronic diseases actually the number of them are increasingly. So in the future, we can expect that we will see more and more patients with these three conditions at once. Regarding to the publication in our colleague from nephrologists in Indonesia, we can see that diabetes is the second most common etiology of the end-stage kidney disease in our country, just after hypertension. According to the ongoing registry of heart failure in our country, they also detect that diabetes is very common as the comorbid in our heart failure patients. At least 1/3 of the patients have diabetes as the comorbidity. So it's really elephant in the room. We need to know about this situation. We need to detect and we need to tackle as early as possible before we going through to treatment for heart failure itself. The pathophysiology of this CKM or cardio-kidney-metabolic, it has a common pathway including inflammations, oxidative stress, insulin resistance, endothelial dysfunctions, as well as the overactivations of neurohormonal. And this put all together to end organ targets. And heart and kidney are the real organ target in these situations. So it will cause from the metabolic disorder like this will end up as the chronic kidney disease and heart failure in the future. So we need to treat them as early as possible to stop the process. This led to the emergence of the new concept of CKM syndrome. CKM syndrome is defined as the systemic disorder characterized by pathophysiological interactions among metabolic risk factors, CKD and cardiovascular disease, leading into the multi-organ dysfunctions and further mortality because of these situations, and is classified to stage 0 until stage 4. In stage 0, you can see the patient is very healthy without any specific metabolic risk factors. And stage 1 begin as the adiposity excess, or what we call as the obesity, without any other risk factors. In stage 2, we can define with patients with multiple metabolic risk factors, including CKD. And in stage 3, we can find a patient with subclinical cardiovascular or heart failure. And the last stage, in stage 4, we can see the established cardiovascular disease. And this is really pivotal important for us to know about these all stages, because we need to screen the patients as early as possible in the earliest stage, so we can stop the progression of the disease, because these all diseases are really chronic and progressive disease. So soon we can intervene the patients in the earlier stage, we will get the better result. That's the whole idea about this new concept of CKD and the staging. If you look at to the old data about the diabetes, there's something interesting. If you look at to the cardiovascular outcome, the cardiovascular complication in diabetes tail off over time. However, the incidence of chronic kidney disease and end-stage renal disease still static over time. It means that chronic kidney disease is something that's really big issue in diabetes. And interestingly, in patients with CKD, they have a higher risk for developing cardiovascular mortality rather than to develop to end-stage renal disease. Regarding to this cohort, for the observations for up to 10 years, we can see the death due to cardiovascular causes can be as high as 27%. If we compare to less than 5% to develop to end-stage renal disease requiring renal replacement treatment. And this risk of cardiovascular disease even higher in patients in age more than 65 years old. Chronic hyperglycemia will cause further inflammations and oxidative stress and overactivation of RAS system and lead to some fibrosis in the glomerulus, interstitial fibrosis, as well as the tubular atrophy. And these all molecular and cellular changes in the kidney will give impact to in the beginning as the hyperfiltrations of the glomerular and leading to the protein leakage, what we know as the albuminuria. So I can say that albuminuria is the first step of the kidney damage, and we need to capture this moment before ongoing process of the chronic kidney disease. So according to the current guideline of KDIGO, we need to start the screening for the CKD in patients with diabetes type 1 5 years after the diagnosis. However, in patients with type 2 diabetes, we need to start the screening as soon as possible after the diagnosis is confirmed. And we need to look into two parameters to determine the CKD existence. First of all is GFR, and then the second is the spot urine albumin creatinine ratio. So it's very important to detect the albuminuria on top of the GFR. And CKD in patients with diabetes can be defined as the persistent albuminuria more than 30 mg/gram and or persistent GFR reductions less to 60 in at least 3 months, or other evidence of kidney damage. So now the classification of CKD, we rely on two parameters. The first one is GFR levels, which is we can classify patients into G1 to G5 according to the level of GFR. And then the second parameter is the level of albuminuria, and we can classify them to A1 to A3. By combining these both parameters, we can predict more effectively cardiovascular outcome in these high-risk populations. So if you look in this graph, you can identify that no matter how GFR the patients, if you find the albuminuria more than 30, we can classify them as the CKD, at least early stage of CKD, and the cardiovascular mortality even higher in these patients with albuminuria in the normal GFR. So now it's time how to manage the patients with CKM syndrome, particularly patients with CKD. Despite the complexity of the cases with CKM, there's a good things that the drugs that is proven from the evidence base and also from the latest trials are quite similar for treating patients with heart failure, cardiovascular, metabolic, and then CKD. We now have 4 pillars to treat these situations with RAS inhibitors, and then the new kids on the block, finerenone with non-steroidal MRA, and then SGLT2 inhibitor, and then GLP-1 agonist. From subgroup analysis from Paradigm and Paragon SF, we can see that even sacubitril valsartan give a positive impact for the renal protections in patients with heart failure, with the reductions of the renal complications in these patients with heart failure. And then this is the landmark trials of SGLT2 inhibitor dedicated in patients with CKD. We have DAPA-CKD with dapagliflozin, and canagliflozin was tested in Credence, and then empagliflozin in EMPA-KIDNEY. SGLT2 inhibitors show consistent result in improving renal outcomes in patients with CKD with or without diabetes on top of the optimal ACE inhibitor or ARB. And SGLT2 inhibitor also consistent in reducing the renal complication, even in patient with heart failure, according to subgroup analysis from DAPA-SF and EMPEROR-SF. SGLT2 inhibitor is known for the direct and indirect effects for these positive results. In SGLT2 inhibitors work in proximal tubule of the kidney and to block the glucose and sodium reabsorptions. But on top of that, they also work indirectly to the hemodynamic and metabolic factors. So we can say the SGLT2 inhibitor has something like a pleiotropic effect in cardiovascular. This is something that really fit to treat so many combinations of metabolic situation, like for the cardiac protections and renal protection, even for endothelial and vascular protections. And of course, we know the SGLT2 inhibitor can also impair the metabolic disarrangements, like to reduce a bit for the body weight, as well as to improve the hyperglycemia and improve A1C in patients with diabetes. And in the end, SGLT2 inhibitor will improve the clinical outcomes, particularly in cardiovascular and heart failure outcomes of the patients with high risk of metabolic risk factors. Other pathway that I want to mention here is mineralocorticoid receptors. It is generally known that minerally receptors of stimulation will cause some inflammation and fibrosis. This is really strong predictor of fibrosis in an organ, such as in kidney, heart, heart, and also vascular. So overactivations of this receptor is something that's really important to tackle if you want to treat the situations in cardiovascular and also the cardiometabolic. And finerenone, as the new kids on the block in this MRA, known as non-steroidal MRA, will inhibit these MR overactivations and furthermore will slow down CKD progressions and reduce cardiovascular risk according to the latest publication that we have. This drug has a short half-life and very minimal side effects, hyperkalemia. If the hyperkalemia is lesser, if we compare to the spironolactone, the other agent of MRA, we have two landmark studies for CKD in patient with CKD with finerenone and dedicated in diabetic kidney disease. So we have Figaro trial and Fidelio. In Fidelio trial, finerenone show renal protections, whereas in Figaro CKD trial, it showed the cardiovascular protection in patients with DKD. And furthermore, in pooled cohort analysis of Fidelity, this trial can show the both benefits of finerenone in treating patients with cardiorenal syndrome. So it's just like killing two birds with one stone. That's why we can say that finerenone is very important in patients with diabetes, particularly if they have CKD, not only to protect the kidney, but also for the cardiovascular outcome. And moreover, finerenone also tested in combination with dual combinations of RAS inhibitor and SGLT2 inhibitor. From the latest trial and analysis, we can see that by adding finerenone to this combination will delay time to kidney failure up to 12 years in patients with diabetes kidney disease. So it's very something important to start. Even if we have given the patient with a dual combination of RAS inhibitor and SGLT2 inhibitor, we need to still check for the albuminuria. If the residual of albuminuria is still present, we need to consider to add on finerenone in such situations to even to give the patient even better outcome in the future. And this is the last trial that I want to highlight here about the GLP-1 agonist, semaglutide, under flow trial. This is the dedicated trial in patients with diabetic kidney disease, and semaglutide show a positive result in renal protections and renal outcomes in this study. So now we have 4 pillars to treat patients with diabetes kidney disease, like I mentioned before. So to conclude, I will say this is the really good time for us. Even we are a cardiologist, we need to understand this whole concept of cardiac kidney metabolic risk. And we need to change a bit our clinical practice by doing like selecting what is the proper treatment for the patient, either to start combination in the upfront combination or sequential. By doing this, we can improve the patient outcomes and we can stop the disease progression. And then we also need to look into the underlying problem of the complex disease, like in CKM syndrome, so we can avoid the polypharmacy. And last but not the least, we need to stop to do a fragmentation of patient care. And we need to treat the patient comprehensively. That's why the multidisciplinary team approach will be fit for these conditions, particularly in patients with CKM. I think that's all from me. I'm looking forward for the further questions. Thank you.
Thank you very much, Paskah, for the wonderful talk. It really just summarized, the current landscape when it comes to CKM management. And what you said was exactly spot on. I think as cardiologists, it's even more important for us to sort of be aware that these medications are out there. It's not just about stents and balloons, it's about prevention, it's about primary prevention and secondary prevention as well. That's why this episode is dedicated to CKM. I have a question because I don't see any questions in the Q&A box just yet. But I have a question, and I'd like to direct this question to Chanchal actually. So we sort of talked about this just a bit, but I just want to make it a bit broader. So first talk was about adiposity, second talk was about CKM. And as Paskah had mentioned, they sort of converge eventually to some form of cardiovascular complication. I think one of the more common ones right now is HFpEF or heart failure with preserved ejection fraction. And most people are aware that that there's a collection of papers out there now by the ACC on adiposity and the hypothesis behind adiposity driving HFpEF. And you have studies to show that, but I think from your group specifically, you've shown that at least in an Asian cohort, we have thin diabetics who have HFpEF. And you also have evidence of drugs like finerenone, which are CKM drugs that work on HFpEF, which don't necessarily work on adiposity that we know of just yet. So is HFpEF an obesity-driven disease, or is it a CKM disease, or is there something in between?
Oh, trust you to ask the best questions, Ezman.
Yeah,
Thank you
20
for the
minutes to think.
question. And I would first start by congratulating Dr. Paskah for that brilliant summary of the drugs available in managing diabetic patients. It used to be just treat the hypoglycemia. Now it's you're conducting an orchestra with all four different classes of drugs and managing them all so beautifully. So thank you for giving us that summary. Coming back to this question, yes, couldn't agree more. We used to think of heart failure with preserved ejection fraction, and we always blame the big systemic issues like hypertension, aging, and diabetes. But more recent work from the big guns in the field has challenged this and has produced the adipokine hypothesis, which completely reframes that story. And in saying that the true driver of HFpEF may not just be high blood pressure or glucose per se, but it's the dysfunctional visceral fat. And that kind of aligns with our findings here in Asia as well. Because in a cohort of heart failure patients, irrespective of their ejection fraction, I'm talking here, if we just look at how, with increasing BMI, there was reduced composite events of heart failure as well as all-cause mortality. And this is true. This is exactly the obesity paradox that we've seen in multiple heart failure cohorts. But what was special about the Asian population was that if we indexed obesity with waist circumference, which was directly parallel to visceral obesity in a subcohort, we saw the exact opposite. With increasing waist circumference, there was increased composite outcomes. So this challenged the BMI paradox. So that brings us to the internal question of whether this whole concept of adiposity could it be very relevant to Asia. Across our region now we see people who are lean but by BMI, and BMI is riddled with a lot of flaws. Let's not even get there. But they're metabolically obese. They are diabetic. They have chronic kidney disease. Women especially, they have a lot more burden of chronic kidney disease, particularly if they're diabetic. And they carry a lot more visceral and hepatic fat. Often these are overlooked by the traditional risk tools, I would say. And this is what we've seen repeatedly from the Asian HF cohorts. Adding to this massive burden, of course, is also the liver and the central obesity, where the MASLD comes in, and the central obesity, early onset of diabetes. You can almost see that the adipokine axis is lighting up across of Asia. And this has like profound implications for prevention and treatment. And that's what we're trying to do in one of the other studies, which is the ADOPT trial. We've spoken a lot about how obesity, the CKM syndrome, keeps these individuals more vulnerable to overall cardiovascular diseases as well as heart failure. But we always often forget that not all individuals are equally vulnerable. They are very heterogeneous when it comes to the risk of cardiovascular events. So then, how do we pick up those who are more at risk compared to those who are not? Because treating them all is not going to give us any benefit. And if you do a trial to treat them all, you're you're more often than other going to end up as a negative trial because of the 80% of the population not being at risk. So how do you identify this green 20% who are primed to benefit from the four pillars that Dr. Paskah just described? How do you do that? And we have tools these days to do that. And thanks to biomarkers, repeated, I don't have to say it to this group, I think elevated NT-proBNP has been cited repeatedly in many guidelines already, that annual screening in diabetic patients may actually benefit them. We are very far from that reality now because biomarker screening is expensive.
Yeah.
And forget biomarker screening, not all our diabetic patients across of Asia don't even receive, many of them don't even receive an annual EGFR or UACR measurement. So we are far from that. But one way to go about it is biomarker in an ideal world, and pair that with maybe even echocardiography screening for symptomatic or like subclinical cardiac dysfunction. I think that will be a very powerful way to identify those at risk for treatment.
Great, great. I think amazing. And I think just 2 days ago, they released an American paper on the utility of anti-proBNP diabetic patients, a very large cohort from America. So again, the evidence is building and hopefully, it gets picked up in clinical practice. But I think you're right. There are tools out there that we can use. But I guess BMI has always been the staple or the standard because it's also pragmatic. Do you have any indices at this point in time that you think is a great measure of adiposity? I hear relative fat mass being thrown around. I don't think it's the easiest to say, but what do you think?
Well, the gold standard will be able to, do an MRI on all our patients to look at the fat, right? But
Yeah,
that's not possible, of
yeah,
course. I would say that I would still say I'm not in favor of BMI. I know it's not a very popular opinion because it is still a very easy thing to do, just measure your height and weight.
yeah, yeah.
But equally easy is to just have an inch tape and get your
Waist
patients
circumference.
measured with waist circumference,
Yeah,
waist hip ratio.
yeah.
And I would argue that holds more credibility over BMI anyway.
Yeah, no, I think spot on. And we've started doing waist circumference in our clinic. It doesn't take more than an extra 10 seconds really, and it goes a long way when you look at your data. Okay, I've got another question. I think, oh, sorry, there is a question in the Q&A, but I think this is very specific to location or geography. Are general practitioners allowed to prescribe Ozempic as off-label drug for obesity management? I know in Malaysia, not just yet, although there have been prescriptions from the community. I don't know, how about Hong Kong, David?
Yeah, thanks for your question. I think in the absence of Wegovy that is licensed for obesity, I think it's basically a discussion with patients about using Ozempic as the off-label drug for obesity without diabetes. So it's really a discussion with patients that this is a semaglutide, but it's not the one that is licensed for obesity purpose. But I think it does achieve a benefit in terms of weight loss. And as we mentioned also in patients with established cardiovascular diseases, definitely this is a choice.
Great, great, great. I think that's pretty much shared by most countries as well. I do have another question for you, David, actually, and this is with regards to the second talk, finerenone. And what I've seen, and this is anecdotal, purely anecdotal, is that the minute finerenone achieved its data results, etc., there has been also a spike in the use of spironolactone as well. Again, whether this is indication creep or not, and is spironolactone the same with finerenone, or is it apples versus oranges in your opinion as an endocrinologist?
Yeah, I think it's really sort of a different mechanism where finerenone acts on to protect the kidney. So it might not be the same in that sense. So if it's really used for diabetic kidney disease, then it's really phenomenal for protection. Spironolactone back to the for example, heart failure, reduce ejection fraction or resistant hypertension, where they would use that. So yeah, I think that's my take.
Great, great. We do have another question actually that just popped up. So wonderful lectures, thank you. May I know the comparison of dapagliflozin versus empagliflozin for the treatment of CKD in DM and hypertension patients without heart failure? Thank you. Who would like to tackle this question?
I
Open.
can have a go. I think
Yep.
at the moment there won't be a randomized controlled trial just for the purpose of DAPA versus EMPA. So
Yeah.
I think it's really up to the interpretation of your data. So if you're a believer that is a class action of SGLT2 inhibitor, then basically that will be the same. If you believe that there are differences in how the trial is being applied, then empagliflozin would have the widest coverage of the whole spectrum of the CKD with eGFR down to 20 ml per minute, where DAPA CKD doesn't have that broad
Indication.
coverage in that sense. So that is depending on how you frame that evidence in your practice. I would believe it's still the use of SGLT2 that is adopted in patients with CKD that is the most important. So my take is that after all these lectures, we've talked about the importance of using BMI and using waist circumference to identify patients with obesity. So that is the most important thing. When you go to clinic, be sure that you attend to the BMI value, not just measure it without action. Secondly, the UACR and eGFR, if there is really a persistent abnormality, do consider at least, first of all, ACE inhibitor ARB, and then also SGLT2 inhibitor, and then if it's persistent, non-steroidal MRA, plus or minus GLP-1 receptor agonist. So that is the most important thing. After all these lectures, we want to put these evidence in our clinical practice.
And a wonderful ending because I wanted to ask you another question, sort of segueing with regards to therapy. And this is
Yeah,
because, from a cardiologist point of view,
yeah,
horizontal approach, everything one go. And then when you ask a
yeah,
nephrologist and they're a bit
yeah,
more cautious, there's also
yeah,
cost
yeah,
implications, obviously.
yeah,
From an
yeah,
endocrinologist point of view,
yeah.
what's your thoughts?
You mean the implementation of all these four pillars, is that right?
Yeah,
So
correct. Yeah.
yeah, I would say it really depends on doctor-patient discussion and the relationship, how patient is trusting us. If in particular, if you are caring for a patient all along, then I think patient might have more sort of trust in you. If you would be the aggressive ones, then you might want to initiate them very quickly, stepwise.
Yep.
That would be possibly a sort of optimal point where in comparison to initiating all four together, because let's say if you have medication that are associated with side effect, adverse events, you don't know which one is leading to that side effect, and that would be sort of a bit difficult. But the most important thing is still rapid escalation of the four pillars. I think the world has been advocating this thing. So first of all, pick up the sign of obesity, pick up the sign of albuminuria, eGFR impairment. Secondly, act accordingly, the four pillars that is applied. And then for obesity, think about incretin-based therapy. So think about the sign, implement them, implement quickly. May not be a once-off approach to add on all four pillars, but at least a really rapid approach. But that will be depending on also local practice, how this rapid escalation is implemented in the local practice, because there are logistic reasons, how appointments are being scheduled, how
Yeah.
quickly they can schedule another appointment for reassessment so that they can step up the pillar. So that's really a bit of variation.
Yeah, I think there's also real world implications that you mentioned with regards to appointments, etc. But the message is rapid up titration whenever possible. Have PEF, DKD, combination, etc. This next question is really for, I think I'll give it to the cardiologist, Paskah. He still remembers, or she still remembers during his or her training 2 decades ago, spironolactone was a drug to prevent ventricular remodeling. Seems like the trend is coming back. I don't think the trend has actually died, but what do you think, Paskah?
Yeah, spironolactone is very important for uh, but especially for the fibrosis. And
Yep.
we have a lot of evidence of spironolactone in heart failure with reduced ejection fractions,
Yep.
even in a patient with very sick functional class 3 and 4 for the heart failure with reduced ejection fractions. Spironolactone is also still valuable in patients with hypertension, particularly in resistant hypertension.
Okay.
So I think spironolactone stands spot on as the important drug. But finerenone, we're still waiting for other trials other than for the CKD even in CKD, it only tested for diabetic kidney
Kidney disease.
disease, not
Yeah.
all kind of CKD.
Yeah.
And in cardiology perspective, finerenone is only available for the patient with HFpEF and HFmrEF. So we still need more data to use it for the patient with HFrEF,
Yeah.
reduced ejection fractions.
No, yeah, I agree, completely agree. And but I guess the appeal of spironolactone is it's a cheap drug. Yeah, it's a very cheap drug.
Yeah.
But the problem is indication creep again, and people are extrapolating data when they shouldn't because steroidal versus non-steroidal is very different. The other thing as well is spironolactone with regards to CKD data isn't very strong. There is no data, to my knowledge, and really with HFpEF as well. Some might argue, the top cat was a negative study, although there was post hoc analysis. But there
Yeah.
is a study for people interested called the Spirit trial, which is testing again spironolactone for HFpEF. So we'll wait and see. There might still be a growing indication for this particular old school drug. Misato, do you have any questions on your end, Misato Chimura?
Thank you so much. So my question is, so first topic is right. So my question is, so HFpEF and adiposity. So in Asia, so severe obesity is less common than in Western countries. So what about Asia phenotypes? So GLP-1 receptor agonist is effective or not in Asia phenotypes? So what do you think?
Should we direct it to Chanchal?
Cancer, yeah, cancer.
Yeah.
Sorry.
Oh, it's too early to tell, I would say, unless and otherwise we measured it. GLP-1, I would say Asians tend to generally show a stronger glucose and weight responses even at a lower BMI. The SELECT trial and FLOW data also extrapolated this very well. But real world data from Japan, Korea, Singapore shows that it's tolerable and it gives you some cardiovascular benefit. But of course, it's again, I would roll back to the same stance that we would want GLP-1 to be tested across of Asia before implementing it because most of these trials had a entry criteria of BMI more than 30, right? And this goes against our
Yeah.
recommended cutoffs for obesity anyway. The WHO recommended cutoff for Asians is 27. So why we are still adopting to the wide population and then getting the data and trying to extrapolate it here. So unless or otherwise it's also been tested in across of Asia, I would be a bit hesitant to use it widely. But and of course, the cost is a big issue in Asia because with limited coverage and it's injectable also. So oral semaglutide is, of course, showing improvement, but is there still a long way to go, I think.
No, I think completely spot on because we've had troubles recruiting patients for these HFpEF studies with obesity just because of the BMI cutoff. And then they add in things like HSCRP. It makes things even more difficult in our lives. Hopefully, the trials will change and adopt the BMI cutoff so that we can answer the Asian question. We do have one question in the audience. I'll try to tackle this. So, what would be your take on eplerenone versus spironolactone in HFrEF? Really, the data is pretty much similar. I think you use eplerenone because of spironolactone's gynecomastia and other side effects. Although the purists would say that eplerenone was really tested for post-MI. I think that's really how they would market it, at least from a company point of view. But in real-world setting, it's pretty much similar. Yeah. Right, and I think we are really, we're close to 7:30. So I think I'll end the session now. I'd like to thank my co-chair, Dr. Misato Chimura, for helping me with today's episode. I really like to thank both our panelists, part of the APCMC, Dr. Chanchal, and also Dr. David Lui, for helping make the discussion really lively with regards to CKM and obesity. I think no better pair to have on today's episode. I'd like to thank Natalie, if she's watching, for contributing to the first lecture and hope she's well and hope she stays safe. And also Dr. Paskah as well for the second lecture on DKD. I think wonderfully delivered. For next month, we are taking a break, but we will come back with episode 4 in January. We'll be talking about acute cardiovascular care and we'll be talking about things like mechanical circulatory support, which is pretty under under talked about in our part of the world. So a lot of topics to sort of peel in that particular episode. The date and all that will be announced soon. So just look out for your social media feeds. And again, thank you everyone and have a great night ahead.